Good evening. Actually, I must thank Professor Srinivas and team for inviting me for this presentation. My one is, of course, a little different one. I'm going to talk about the coronary and cerebral steal syndrome, the interventional approach. I know this is not a very common.
Okay, please go ahead.
Yeah, this is her clinical summary. This is a 63 years old female. She had bypass surgery in 2007. She had two grafts, Lima to LAD and radial artery to D1. Had multiple risk factors. She has been long-standing diabetic for 2002, hypertension 2010, and hyperlipidemia. And as a result of diabetes, she had CKD stage 3. She presented to us with worsening angina for the last 1 month. Clinical examination was unremarkable. Echo showed ejection fraction normal, is about 60%. She had high serum creatinine, about 1.5 milligram per deciliter. Hemoglobin was reasonable, about 11 grams per deciliter. And with these symptoms of angina, we proceeded to go ahead with coronary and graft angio. And this is her native angio. You can see the left system is totally gone, LAD and circumference totally gone. And we do the right corner, you can see a new lesion appearing, a critical lesion in the RC osteum. And we did the graft angio. This is the radial artery angiograph to the D1. You can see a critical stenosis in the proximal segment of the graft. And we were trying to engage Lima. Unfortunately, you can see the subclavian artery is totally occluded. So he has three problems. One is the patient comes with angina, had two grafts. Both the main problem, Lima is totally gone because the subclavian artery totally occluded. The radial graft is also a critical lesion and a new lesion in the RC osteum, and there is a sizable vessel. So considering the problem, subclavian intervention is not as easy for a current interventionist. So we started with uh, intervention to the RCA, and this is the lesion. You can see the critical osteum, and we put a stent, dilated and put a stent, 3018 drug-eluting stent, and then you can see. I don't know. You can see the picture fully. The RCA is fully opened up. Then we moved to the radial artery after a few 2 months later because of the renal problem. We had a stage procedure, and the graft we again dilated and put a stent, and then this is the final result of after the occlusion, and we have got a very good result. But unfortunately, after these two interventions, patient symptoms did not improve very much. So we had to, the angina and dizziness on exertion persisted despite PCI. So we had no choice but to plan and do the subclavian intervention. Uh, though we have experience as a coronary, not very good. So this is the picture. Actually, we didn't see anything, so we can't get any picture from the femoral root. I did put a left radial catheter, and you can see it shows a critical osteal stenosis of the left subclavian, and we managed to engage the catheter, see the stem very, very critical near total occlusion of the subclavian occlusion with the diagnostic catheter, you can see. Then we decided to cross this lesion. This is the guiding catheter. We use a coronary wire. The one thing is a small, and we are more familiar with coronary. And we are able to cross the lesion with the O1 for coronary wire and place by the distal subclavian artery. Next, we took a small balloon because of this critical narrowing. So we dilated with a 2 millimeter 215 coronary balloon, and then went to 312 balloon gradual inflations, and finally with a 4 millimeter balloon. And as a result, after three serial dilatation, we got a reasonably good result. As you can see from this picture, the osteum is quite open now. Next, we decided to stent. As you know, the coronary arteries won't take the peripheral stents. And we had to go for femoral because subclavian, the left radial, actually it would have been easier to go for left radial, but the catheter won't take the radial, so we had to go for femoral artery. But I put the catheter to see the position of the ostium. And now you know this, we can't use the self-expanding stent at the ostium, so we use the balloon expandable stent at the ostium. Now we inject from the catheter, and you can see it nicely covers the ostium. And then we deploy. It's a really tough lesion. It has put them in block for a while, and we open finally up to normal levels. And you can see now it's fully deployed and fully opened. And that is the picture after inflation. I'm just showing the final results of the picture. You can see the subclavian artery is nicely opened. And you see, when you inject from the left radial artery, you can see the subclavian fully open and lima is nicely functioning. Though this is not a very common issue, I know this is a we occasionally feel, but this is a very challenging for a coronary interventionist because we should have some exposure to the peripheral. Because I had in the past one patient, one of my colleagues had dissected subclavian artery, and which is totally occluded right subclavian. So fortunately, I had few coronary so peripheral stents, so I was able to rescue the patient. So my discussion, I would say subclavian narrowing is commonly due to progression of atherosclerosis in proximal subclavian in patients with ischemic heart. This is not uncommon. So most patients are asymptomatic patients. We don't have to do anything. But some patients present with subclavian still syndrome due to flow reversal in the vertebrobasilar, the reversal shunt, they can get still syndrome in the cerebral surface causing dizziness, some claudication, and patient with or narrowed subclavian artery, when they do exert the left hand, they get subclavian steal to the coronaries, coronary subclavian steal syndrome. And in the past, the surgery was the standard therapy. Now we know the PT and stenting is an accepted strategy for symptomatic patients and gives very high good success rate and very good long-term patient and very few complications. But though the long-term pain is good, but you have to keep monitoring these patients as recurrences has been reported. Therefore, it's better to monitor this patient long-term with pulse, blood pressure monitoring in both arms in regular intervals. So, my take-home message actually, subclavian stenosis, regardless of symptoms, is a mark of atherosclerosis and increased risk of cardio and cerebrovascular complications. Coronary subclavian steal syndrome should be suspected in patient presenting with the CVD patient presenting with angina or myocardial infarction. That is may not be uncommon. And peripheral intervention experience is of enormous value in dealing with such patients with isolated subclavian stenosis. Okay, that's mine. Thank you.